Oh, hello and welcome. Glad to have you with me for another round of digital slide review and sign out. I'm Dr. Lewis Hassel from the University of Oklahoma Health Sciences Center, and our program is part of the Digital Anatomic Pathology Academy, one of the services that you get as a member of the Digital Pathology Association, complimentary to members. So our case today, a very quick case, comes from the realm of GI pathology. The patient is a young adult, 35-year-old male who has experienced fairly long-standing diarrhea and now has a radiograph anomaly, abnormality of some thickening and so forth that looks like it may be a mass lesion, raising concern for possible neoplasia. So that leads to some investigation, unable to identify immediately a cause for his diarrhea, which is vaguely watery, but not particularly profuse, as well as then consideration for biopsying or resection of this area of abnormality. As a matter of course, in this course, we try to consider some of the things that are in the backdrop. And although chronic diarrhea has a differential diagnosis that's longer than I am tall, there are a number of major things to be considered. The inflammatory syndromes, inflammatory bowel disease, various infectious causes, malabsorptive causes, neoplastic things, endocrine tumors, and then just a host and litany of other things. It includes medications and so forth. So I'll put in the references for this video, a nice reference to a good general article dealing with this differential diagnosis, some of the things to consider clinically to be more exhaustive in that treatment. However, suffice it to say that this came to the surgical pathology bench, and that is where the interest that we have lies. So here's a low power view of a portion of the bowel wall from this patient. And as you can see here, the mucosa looks, a little bit undulating and so forth. There is maybe not a whole lot of fat here in the submucosa. But the thing that should jump out at you right away is what's going on here between the layers of the muscularis propria. And so naturally, your eyes are going to be drawn to that. But let's first look and do this in a systematic manner. Look at the mucosa. We see that it's fairly normal colonic type mucosa. We don't see organisms here. We don't see abnormal inflammation. The spacing of the glands is good. There's a lymphoid aggregate here. Looking in the submucosa, we see that in fact here there's also a degree of what you might term neural hyperplasia here. There's quite a few little bundles of nerve twigs here. And that may correspond to what we're going to see a little bit deeper down. We can see that some of these have associated ganglion cells as well. And so looking then into the muscularis, we see one of these nerve bundles coursing down between the fibers. And then as we get here in betwixt the two layers, we see this prominent areas of neural or glial type tissue with abundant numbers of ganglion type cells, which you can see here have the eccentric nuclei, have sort of amphiphilic appearing cytoplasm, and they're just sort of coursing here in between these circumferential and longitudinal layers of the muscularis mucosa, forming quite a hyperplastic appearance here, or almost hamartomatous. And in fact, clinically in this situation, they were causing a bit of mural constriction and abnormality, giving the impression of a clinical mass lesion. Looking beyond this into the adventitia, we see a nerve here. So there's not quite the same degree of neural hypertrophy in the adventitia, although certainly their nerves are quite common here. So what is this entity? Well, this pattern of diffuse neuroglial proliferation with associated ganglion cells has been termed ganglioneuromatosis. And there you can see nicely those things. So this is an entity that is recognized to occur in the GI tract and is essentially a hamartomatous type of increase in the glial and neural elements, primarily within the muscularis, though as we saw, there is some spread over into the mucosa, submucosa as well. Now, this is often associated with a syndrome, and that's important to understand that if you see it, you should raise that question, either neurofibromas type 1, neurofibromatosis type 1, or multiple endocrine neoplasia type 2B. However, even the sporadic cases are oftentimes associated with RET mutations, as might be seen in men 2B. This location in the bowel wall may produce the mass effect, as we've indicated. And the differential considerations would include, at least from the surgical side of things, solitary polypoid ganglioneuroma or multiple polypoid ganglioneuromas, as may be seen in Cowden syndrome. So another reason to consider the genetic backdrop of the patient. So that concludes our case today, diagnosis of diffuse ganglioneuromatosis, causing in this patient a diarrheal syndrome and leading to the partial resection of the affected segment. Well, we hope you liked that quick case, and if you did, you'll give us the thumbs up. Please also subscribe so that you'll catch future releases from our channel. And if you have comments, we welcome those. Suggestions, also welcomed. And if you need to reach out and contact me for any reason, my contact information is here as well. So until next time, thanks so much for joining me.